No, it's not.
Oh, because well, anyway, some of the lettering is different from what I made. But
Yeah, it's Linux. My apologies to everybody.
oh, we cannot help that. That's a pity because, well, we'll see. I'll start talking anyway. But this is something for next time, that you better use the same computer as the person who sends you it. But no problem. Okay, I'll start all over. I'm going to talk to you about safe tapering of medication with tapering strips, shared decision making, and shared understanding. Now you have to click. Yes, this is the problem for which we want to find a solution. I'll read it again. In the Netherlands, more than 3 million people use medications such as antidepressants, antipsychotics, benzodiazepines, opioid painkillers, often for an extended period. Worldwide, this will likely be hundreds of millions of people. When it is not possible, you go too quickly. When it is not possible to discontinue this medication responsibly because the dose has to be reduced too quickly and in too large steps, problems can arise. These problems can range from minor to very severe, including complete destabilization, psychotic episodes, suicidality, and even suicides. And this not only affects the persons involved, but also their loved ones, healthcare providers such as general practitioners and psychiatry, and society as a whole. And because so many people are using these medications, this problem affects us all. And it's a pity. Can you make it small? Well, okay. And this is my mission, our mission, I might say. The next one. Yeah, to make responsible and personalized tapering of psychotropic and other medication practically possible based on shared decision-making and proper self-monitoring. I myself and Jim van Os are involved in the development of and research into the use of tapering medication, but not in producing it or providing it to patients. We do not receive any reimbursement or income from the provision of tapering medication. But the User Research Center at UMC Utrecht has benefited from a personal grant of the Regenboog Pharmacy. I'm trying to click something away here on my screen, but it doesn't work. My name is Peter Groot. I'm not a medical doctor. I studied chemistry, biochemistry, molecular biology, and for many years I did fundamental genetic research, and I got a PhD in 1989. And I've got lived experience with depression, with suicidal thoughts. And as a result of such depression, in 2004, I started using antidepressants. And I discovered that I was suffering from withdrawal after forgetting one single daily dose. And in 2014, I did an experiment tapering my medication hyperbolically and slowly, stepwise, using very intensive monitoring, daily self-monitoring. Yes, Paul. And I got a bachelor in psychology in 2012 for a study which I started when I was in a period of unemployment. And I wrote about my depression, and if you want, you can read it. Here are the publications. Next. These are the problems I see with prescribing and tapering. First of all, there are no good guidelines. And the recommended dosages are problematic because it's basically one size fits all, and you can see this in this figure. A few dosages for tapering are not enough. We generally have only a few dosages for prescription drugs, while what we need is what we need with shoes and with clothing. So what we need for safe tapering is basically all the dosages that we need for a gradual taper. And to make this possible, very low dosages are required. The problem is pharmaceutical companies did not supply them, and psychiatry did not ask for it. Next slide. And an important thing to remember is that guidelines for withdrawal are based on group research. They do not account for heterogeneity well enough. And that's important because we know large inter-individual differences between patients exist. If we would know, if we could measure withdrawal risk for individual persons reliably, we would probably come up with such a graph where we can see that some people can have low risk of having withdrawal and some people have high risk, and many people are probably somewhere in the middle. And this creates a big question, the next slide, for doctors who want to help patients and for the patients itself. Because the question, of course, is if you want to taper gradually, how gradually do you want to taper? Are you one of these patients who can taper fast? Are you intermediate? Or are you somebody who has to taper very slow? This is very hard to predict. This is on the next slide. Because the susceptibility for withdrawal, for an individual patient, it's almost impossible to predict reliably if and when withdrawal will occur, how bad withdrawal complaints will be, and how long they will last. It's very difficult. And for responsible tapering, it is very important that it can be individualized, that it is flexibly adjustable. And what I find very important, that we can use proper self-monitoring, and shared decision is important. And what often happens in clinical practice is that a doctor and a patient both know not precisely what the best course of action will be. So there are choices, uncertainties. And in my view, if this is the case, shared decision is important. But if different choices can equally work well, we don't know this. I think it should be the patient who decides this. Yes, next slide. And this is something that many patients have understood at an early stage, earlier than many professionals did. What you see in this slide is this comes out of study out of 2021, in which an inventory was made of a number of Facebook group websites made by persons with lived experience with the goal to help each other. And it's amazing how much knowledge can be found on these websites. So it's patient-developed knowledge. Next slide. We've described the origin and the history of tapering medication in this paper. And I want to stress that the next one, or the next, yes, that tapering medication we now have in the Netherlands was made at a request of patients. We were approaching pharmacists, and we found Paul Harder with the question, are you able to do what pharmaceutical companies have not done and what psychiatry had not asked for? Help us to make this medication. And that was in 2013. Now, next slide. This is how tapering strips work. It's basically a very simple way to solve a problem. And the idea for this was put forward by a patient who could not come off his benzodiazepines for a number of years. And it was put forward in 2004. And what you see here is no.
Sorry.
The way it works is just like with the coins in our wallets when we want to pay a certain amount of money. If you have coins of a number of different denominations, you can make every amount of money with a minimum number of coins. And the same is true if you want to make medication at all sorts of different dosages. And what you need is a way to package this, and that's why we call them strips, because Baxter strips were already in existence. So that's how we did it. Next. And this I'm going to read out, and what I want to make clear is that in the discussion between patients or between a doctor and a patient, I think it's important if we have a way to explain tapering in the simplest way possible. So without going into detail about pharmacokinetics or pharmacodynamics or about receptors or about biochemistry or whatever. So this is our way to try to explain tapering as simple as possible. So what I would tell somebody if he wanted to taper safely is the following. The responsible way to taper off medication is to do so in a greater number of small steps, with each step getting smaller as the dosage decreases. Next. Because this will allow your body to adapt to the progressively lower dose after each step. And with ample time for adjustment, you are less likely to experience symptoms while you are tapering, or hopefully no symptoms at all. For if any symptoms arise during tapering, they will probably occur less rapidly and are less likely to become severe immediately. And this is important because this makes it easier, both for yourself if you are tapering and for your healthcare provider, to address these symptoms in a timely manner, such as by remaining at the same dosage for a while before continuing the taper more slowly. And what's important to always discuss is that the possible outcome of tapering may, of course, be that there comes a decision to continue using the medication, possibly at a lower dose, perhaps not. But it's clear that not everybody will probably be able to come off medication. But the important thing, that's the last one, is that opting for such a gradual and responsible approach to taper makes it easier to explore whether tapering is feasible for a patient, because patients often want to come off medications and they will try it anyway, even if a doctor says you cannot do it, and this allows you a way to do it jointly. Okay? Now, the practical question, how do you choose a tapering schedule when you and your doctor don't know if and how much you are at risk for withdrawal? Now, we use this method, which is so nicely set out by Mark Horowitz and David Taylor in 2019, this gradual hyperbolic taper, which looks like if you're going down a slide. And what you do, well, it's possible to ask a personal advice if you want, and then you are told this is a schedule that might well work for you. We're not sure, but this you can do. And then if you use the tapering strips, then it goes like this. You have one strip for the first stage of the tapering, then follows the next one. Can the next one come? And then a third one and a fourth one in this example. And since all the tapering strips made, we have chosen for a period of 4 weeks. So you can choose if you want to taper in 4 weeks, 8 weeks, 12 weeks, and so on. Now, of course, the problem, if you make such a choice, you're not sure if this taper will be good enough for you. It may be too fast. So what happens if that occurs? Well, that you see here, you start tapering with the first strip. And as long as everything goes well, you can probably just go on tapering. And if everything works as planned, you can taper without problems. But if you start getting symptoms here, then what you should do, and that's on the next one, is do not go on with your taper, because common practice is if people do that, almost invariably your complaints will get worse. So it's not a very sensible thing to say like, oh, but I will get through these complaints, I will just go on. You better not do this. Stabilize first, and then if that works well, you can decide to slow down. But of course, you can also make another decision. That's a discussion you have to have with your doctor. That's something you have to think about yourself. Okay, next one. The next one is something we have given a lot of thoughts, and that's the importance of self-monitoring. We wanted to have something for patients which they could do. Yeah, the next one can come. Which they could do themselves easily. And we did not want to make complicated questionnaires where you ask all sort of questions. Do you have this kind of symptoms or this kind of symptoms? Because the simpler you make such a tool, the bigger the chance that people will actually use it. So what we ask people to do is in this table, if you go through it, you see the number of the days. It goes from 28 to 1, the days of the week, and you see the dose of the medication. And we ask people to fill in a score of 1 to 7, which is the score of the complaints people experience when they are tapering. It's a subjective score. And so it can mean different things for different patients. But the important thing is that if patients do it every day, you can see if things are changing while you are tapering, because that's relevant. Also, people can write down which complaints are you having. And I want to point you at two interesting things here. And this is actually the first self-monitoring form we ever got back. That was this woman in this case, and she was stabilizing diazepam, because apparently she had a lot of complaints while she was trying to come off diazepam, because she is filling in a 6, 6, 6, 5, 4, 4, and then you see that it gradually goes down. But what I found interesting when I saw it was this remark: performing with the choir went well. Because this is not a symptom. I mean, this is something this woman experienced, and which my take is was important to her. Probably performing with the choir went less well before she started doing this. So it was informative for her, and it's probably also informative for her physician. And that's what we want. The second thing is, next one, please, that she writes down, therefore using mere seroquel, more quetiapine. Why is this important? Because he says something about the dose change of another prescription drug. And this is something which happens quite a lot in daily clinical practice. People who are tapering, not rarely, are also using other medications. And it's important to know what happens. And this also makes the whole tapering process more complicated. But this way you learn something from it, both the patient, but also the GP or the psychiatrist who helps this patient. And finally, at the bottom, no, please go back.
Yeah.
Yes, this one. What this woman writes down is that sleep has successfully recovered during this stabilization. Dus during these 28 days, she was feeling better while she stayed on the same dose. This is very relevant information and important for her. And then she says, I will now continue the taper. So it's her decision. And I think it's a joint decision with the doctor, which is helpful to get through this process. Next, please. This is the second example we got in. And this is somebody who is tapering an antidepressant, clomipramine in this case, from 75 to 50 milligrams. You see the dosages here. And you see the score is 1, except for 3 days. So what happens with this person is that he or she is tapering and is experiencing no problems at all. So what this tells, and that's also the conclusion of the patient, it's going fine so far. So I can just go on tapering, and then we hope that this will go on to the very end. Next one. Oh yeah, this one. So this is what our goal was. Make a form as simple as possible, easy to fill out. And because we can note the changes, it tells us something how and when symptoms change as the dose changes. So this is informative for both the patient and for the doctor and for perhaps other persons are involved. And we have tried to come up with some what we call universal rules for responsible tapering. Well, the first one is very clear. If you change your dose, do it gradually. And this is not only important, I think, for tapering, but also for starting medication. I mean, rapid, abrupt changes of medication can be a source of problems, so we must be aware of that. The second thing is shared decision-making. Patients have to be involved. The third one, I think, is daily self-monitoring. And the fourth one is take the time that is needed for a taper. I mean, if you go too fast and you get problems, you gain nothing. And finally, if you experience complaints during your tapering, do not continue tapering when things start getting worse. Do discuss this with your doctor to determine whether and how to adjust the tapering schedule. And when the doctor is not readily available, you have to think about it yourself and perhaps take a decision about what you are going to do. But not simply go on with the tapering, because often people regret this when they do this. Next. Now, an important question, of course, is do tapering strips help? Because by now in the Netherlands, more than 10,000, I think it's 12 or 13,000 people have been prescribed tapering strips. We have been able to ask these people how things were going. And thus far, we've done 4 studies with a total of now more than 2,800 participants. I will not discuss these studies in detail. I will only give you the results. That's on the next slides. Oh, before I give the results, I want to say something about the patients who participate in these studies. First of all, many of them are long-time users. Secondly, many had tried to come off medications before, often several times, and when they did this, on average, they suffered severely from withdrawal. And there were also, especially in the beginning, many patients who had to inform their doctors about the availability of tapering strips instead of the other way around. I think currently in the Netherlands, things have changed, and a lot of patients are told by their doctors, oh, I have something for you. And finally, we gave no additional guidance except for the information that we provided with the tapering strips. So there was no additional support whatsoever. And what we are seeing here, and this is important to realize, this is very different from what happens in clinical trials. Because in clinical trials, patients are often not representative of patients from daily clinical practice because, next one, there's exclusion of patients who do not have a certain diagnosis or who also use other medications or who have suicidal thoughts, etc., etc. And that was not the case in our studies. Now, what are the main results? First of all, in all studies thus far, about 70% of the people who used the tapering strips were able to taper completely. And this was also true for patients who had tried to come off their tapering strips before, and that was more than 60% of the patients in our studies had tried this. Secondly, we were able to measure, because tapering strips have been in use starting from 2013, to ask people who had tapered 1 to 5 years ago. And of them, 70%, roughly 70%, were still off the medication they had tapered using tapering strips, which leads us to conclude that we think that an as yet unknown, but probably significant number of patients appear to be able to come off psychiatric drugs like antidepressants, even after years of use and after several previous failed attempts to quit. There's one important provision to be able to do this, that doctors will be able to prescribe personalized and easily adaptable tapering schedules based on shared decision-making and proper self-monitoring. And to be clear, whether this is done using the tapering strip we have developed or by other means, by using liquid medication or whatever other methods, that's not relevant here. And important to note about the availability of tapering medications, they are available in the Netherlands for antidepressant, antipsychotics, tranquilizers, opioid analgesics, anti-epileptics, and some other medications. And we also have developed switch strips to help people make a switch from, for instance, one antidepressant to another, which is a common clinical practice. And in general, tapering medication is also available for patients outside the Netherlands. I can see it on my screen, but if you go to the website www.taperingstrip.com, you can find the information there. Now, the next thing I'm going to talk about is alternatives. Yes? It's important to know that all over the world, great work is being done by persons with lived experience to help each other. I noted this before, and here you see an example. This is from the Inner Compass, the withdrawal project. And it's amazing, they have really detailed guidelines on how to kind beats, making a liquid mixture, using a digital scale. They give you information about which scale you use. And I found information there about things that I was taught when I was a first-year chemical student. So they do really great work and they help a lot of people. Let me see, where am I? But I have 3 ethical questions, which I will end my talk before we go to a discussion. The first one is this, and we asked this question in the Pharmaceutical Journal in a short reply we wrote some time ago. Is it fair to burden patients with responsibilities typically handled by trained and certified professionals, such as pharmacists who have the expertise and equipment to adjust dosages when necessary? I'm not going to give you the answer. You have to think about this yourself. Next one. Oh, no, please don't move. This is a table we made in which we compared tablets and liquids. And when we were making the tapering strips, we have also been thinking about other alternatives. And this is our interpretation of the differences between these 2 solutions for responsible tapering. And you could make similar tables for other methods, but we just compared these 2 because there is great demand. A lot of people ask for liquids, and What we've done here is, if we think that there's an advantage of using tablets over liquids, we've indicated the plus, and if we think there's a disadvantage, we have noted the minus. Probably we are biased, but we have set out a number of things, and one of the few things we say that is comparable, that is flexibility. But there's a lot of issues, sensitivity for temperature, shelf life, scientifically proven. I think we have provided evidence for the use of these tablets, and as far as liquids go, I haven't seen it. Then there are production costs. There's something that it's very easy to receive tapering medication because it comes in an envelope that just comes into your mailbox, so you don't need bottles. Then there is the logistics, and for a patient there's also a matter of convenience. With the tapering strips, you just have to take your daily medication and that's it. You don't have to. Is there somebody making noise?
Ik heb hem wel gezien. Ik geloof dat hij in de...
Luid uit, Paul.
Ja, dat is dan.
Oké. I hope. Paul,
Ja?
zet je geluid uit.
Wat zeg je?
Zet je geluid uit.
Ja. Oh, ja, sorry.
Even eentje terug. One back, please. One back. I was not ready yet. Because there are also the convenience of the instructions. You've seen the instructions on Inner Compass, which is all very nice, but it's asking a lot from patients to do this for a period of months or perhaps more than a year, every single day, with every single day a possibility to make errors. When liquids come in bottles, they can break. And so these are a number of things. That is what we see. Next one. My ethical question 2, my second ethical question, is that generally patients are allowed to continue using prescription drugs like antidepressant for years or even a lifetime, also when they don't need them anymore, but are unable to stop due to withdrawal complaints and difficulties caused by it. Let me see, is this the correct one? Yeah, and when patients want to be able to taper safely and responsibly using tapering strips or prescription drugs in liquid form, or they need a weighing scale or pill cutters or any other means, currently they have to arrange for this themselves and they have to pay for these tools themselves in general. Now my question is, and you can give the answer for yourself, is this fair? And now we go to my last ethical question. And this is a New York Times article from a year ago. And what you see is that Mercedes-Benz had to recall nearly 1 million vehicles because there were brake issues. So what we see is that the manufacturers of cars with malfunctioning brakes had to recall 1 million cars and had to recover all the damages caused by these faulty brakes. Next one. And we consider this a normal thing to do. Now, next one. But we do not demand the same from pharmaceutical companies that have introduced prescription drugs with faulty brakes. Next one, please. While pharmaceutical companies have been aware of withdrawal issues for decades without being compelled to address these problems. Next one. And if I go a little bit further, in the case of opioid painkillers, the Sackler family knowingly exacerbated withdrawal problems by producing oxycodone tablets with an extra high dosage, making it even more difficult for people to quit all to maximize profits. Next. And this, we know, has resulted in over 500,000 deaths in the past 20 years. Pharmaceutical companies involved were assisted by consulting firms such as McKinsey, which recently settled a case in the US for $230 million about these issues, in addition to a previous settlement of $600 million. And here is my question about this. Given all these things, is it fair to let patients pay for the damage? Again, this is a question you should answer for yourself. And then my final slide, this sort of wraps it up. Just take a look of it, and then the thing that's beneath it, next one. That's my question. What I see is a barrier of injustice, and that is that we make patient pay to be able to taper safely. And this is what I wanted to tell you. So, if there are any questions, we can discuss.
Christoph, thank you so much, Peter. I give entrance to whoever wants to question.
No questions?
If there is none, I would like to know, have you been involved, at least cooperating with the Radar project that was recently published in Lancet by Moncrieff, Dr. Moncrieff?
No, we were not involved in that.
Mm-hmm.
We followed that.
Peter, I have a question. Do you hear me?
Yes, I can hear you.
How do we find patient who was had a damage by this treatment to go to a court with insecurance for rights, for law cases, to go to the court until the European court? How do we find such a person with Rechtsschutzversicherung? I do not know that, who has not to pay personally for all the costs when he goes to law. How do we find such a person?
I understand your question, and my answer would be go search for it. But it may be difficult because it's difficult for an individual patient to go into such a trajectory, because it's going to be long, it's going to be difficult. And you have to find the legal assistance to make this possible, and that's altogether not easy. So if I could tell you more, I would, but this is my take. So anybody else? No?
I got a question.
That's fine.
So on average, if the people in Netherlands were taking depression pills for more than 2 years, on average, how many months or years did it take them to get to zero?
That's very different from patient to patient. I mean, as I said, some people can stop rapidly, even from a medicine like venlafaxine. There are people, and I have spoken to them, and they said, I stop, and for 2 weeks I have very heavy dreams, and then I'm fine. I think these individuals are rare, but they exist. At the other extreme are patients who go very, very slowly, and even if they come to the end, it may be difficult. And I can use myself as an example. I mean, 10 years ago, I tapered my venlafaxine in a period of 8 weeks. I did it gradually, stepwise. The paper is published. And I had thought about it a lot. And at that time, we thought that 8 weeks was quite a long time because everybody tapered much faster. And the way I tapered went fine for me. I mean, I was aware while I was tapering that something was happening, but because I expected that something was happening, if I felt a little bit light in my head, I did not really experience this as a big problem. In fact, I expected it, the things went well. And then after 8 weeks, I thought, well, I've done it. But within, I guess, about 2 weeks, I started to having complaints, mental complaints. I started worrying again, and this didn't go away. And this was nasty. So I don't know precisely how long, but after a few months, I decided I'm not going to take this because I'm afraid things will get worse. And well, my father, he made an end to his whole to his own life more than 40 years ago, and I was sure I did not want to do that. But I could not exclude that if I started feeling worse and worse. So I thought about it and said, okay, I'll go back to the Venla vaccine. I don't know if I suffer from withdrawal. I don't know if I have a relapse, but I will go back. And I had always used 150 milligrams. So I said I will do the same as when I started it, go from 0 to 37.5, wait 1 or 2 weeks, and then go to 75, and then again wait, and then go to 150. But when I got at 75, I noticed that I was feeling so much better that I said, wait, before I go higher, let's stay on this dose. So for 10 years, I've been using 75 milligrams of Venla vaccine, and I was fine. Now, this year, with the knowledge I now have, and with the tapering strips available, which were not available then, I said, I'm going to do a second attempt. But this time, I will do it slower, and I will use the tapering strips. Now, in 2012 or 13, I don't know precisely, I tapered in 8 weeks from 150 milligrams to 0. This time I tapered from 75 to 0 in 20 weeks. So I tapered 5 times as slow. And the big difference with my previous taper was that I did not notice any complaints during the whole 5-month period. What was happening, I had these forms I had developed myself, these self-monitoring forms, and day after day, I forgot to fill them in. And if I had to fill them in, I could just fill in 1, 1, 1, 1, 1, because I was fine. And of course, my big question was, after I tapered completely, and I expected that this would work well because it worked well the previous time, what will happen next? Now, it's about 5 months ago, I think I stopped, and I've been fine. So the fact that I tapered 5 times as slow as 10 years ago, for me, made a huge difference. But how this is for other persons, that depends. In the research we have done, we have analyzed about 1,800 of these self-monitoring forms. We find patients who, just like I did, fill in 1, 1, 1, 1, 1, 1, 1 over the whole trajectory. We also find patients who go much slower and still have a lot of problems. And we also know that some patients who can taper safely can get complaints back after they have stopped successfully, sometimes quite a while after, and we still don't know what causes this. So I cannot give you a clear answer. What I can say is that it matters if you taper gradually. But we still have to learn a lot. So I hope that's an answer that's clear for you.
Thank you,
All right.
Peter.
I can give an answer.
Okay.
On the side, tapering strip, you can find a form to ask for advice. And then we give you an advice for the tapering trajectory for the patient.
Yes, but
Based
still,
on the information we ask for.
and we are keeping track on this information to find out how well these advice works for the people currently.
Yes.
So
In
in view
which
of,
language? In which language can people ask?
sorry,
In which language can people
In
ask?
which language?
in a number of different languages, because the
Spanish, Portuguese, English, German,
German,
French, Dutch.
French,
So
Okay. Thanks.
So, Mr. Lehman, you can
No.
read it also.
you already knew some of these things. Anyway,
When you are here, can you tell me, are there any orders of German people or people from Switzerland or Austria?
Paul, I cannot tell this, Paul can.
Or
What's the question?
the question
Well-
is,
What
do you
is the
receive
question?
orders for tapering strips from Germany, Austria?
Whether you receive requests from people to send tapering strips to, for instance, Germany or Austria, or your screen seems to be frozen. I don't know if perhaps we can go to another question and wait to until Paul comes alive again. My understanding is that these requests come in and that Paul handles them. And also I get emails sometimes from very different countries from people who I answer. So I saw another question from Beatrice. Please talk.
Yes, many thanks for your talk, Peter. I will try to express myself in English. If there's some problem, I will go to Spanish.
Somebody has to translate. My Spanish is not good enough, but we will get there.
Okay, let's try in English. I have some curiosity about why you choose to speak about shared decision making and not maybe supported decision making, like, because on your talk you were like saying that the last word was from the person who was doing the tapering, the patient, no? And
Well,
also, this is related, I will finish, so because it's related with
yeah.
another thing. I think also that all your ethical questions to me were signaling that the need for some support on tapering being recognized as a right that you have to get some support to make a process of reduction or withdrawal of psychoactive drugs that you have been prescribed. Sometimes maybe you could be in a process of forced medication or so. I was thinking if in Netherlands it is recognized as a right, if you find in the way of that to be recognized as a right, as a civil right, but also as a human right, like to have that support if you want to do that process. I've been working a lot with the Convention on the Rights of Persons with Disabilities, and this is why I'm asking, why not supported decision making and share it? I don't know if I explained myself properly. Yeah.
I will sort of try to give back what I understand from your question. To begin with, I don't know precisely what the difference is between supported decision making and shared decision making. So I don't know if it's very useful to start elaborating on that. My point was with this point, like if there are certain moments of uncertainties, what I meant was very concrete. If somebody wants to taper vanilla vaccine, and if they would ask Paul an advice, and then he looks at how many years have people used this medication, which medications they are using, he can say, like, you go from 75 to 0. It could be a good thing for you to do this in, say, 4 months or whatever. Then the advice he is giving is not an advice of which he can tell 100% sure that this will be good enough for this patient. Perhaps this patient can. And the thing is, the patient and the doctor take this advice, but they take the decision, and they don't need to stick to the advice Paul gives. There are situations in which patients say, if you say, I'll do it in 4 months, they say, no, I want to do it in 3. And this is what I mean when a patient and a doctor are discussing tapering, and they both don't know if 3 months is the right period, or 4 months is the right period, or 5 months is the right period, then all these different choices can be right choices, perhaps not, we don't know. And then I think that the patient should be the person who can take this decision. It's his or her life. And as long as you follow the tapering while you are tapering carefully, and you have the possibility to do something once you get complaints, then I think this is fine, because we cannot predict how things will be going. I mean, tapering is a process where you have to decide during the tapering process. It's not like looking in a guideline and saying, oh, this patient is that old, has this and that, so that's the period he or she has to taper. We simply cannot do that. And therefore, it's a joint process. And there's one other thing, when we are talking about rights, it's a fundamental right of patient, at least in the Netherlands. If a patient says, I want to stop my medication, then there can be a situation where a doctor says, no, you cannot do this. But if a patient decides, it's the patient choice. So, but that's a different matter. I think in most cases, patients and doctors both have common interest to come to a shared decision. That's my whole point. And whether this is supported or shared, I don't know precisely the difference, but for me, that's not the most important point. I hope this is an answer that will be helpful for you.
Yes,
Peter,
it is. Many
Peter,
thanks.
Peter, if you come from the human rights discussion, then Beatrice refers to the right on bodily integrity, and it's a human right which is not dividable. So there cannot be a shared decision, because you cannot share human rights. This is the point. Of course, your explanation makes sense too, that in a discussion there should be a joint decision, but finally, from a human rights perspective, it's the patient who has the final decision. But this topic about human rights, I will speak in 2 hours about it at 6 o'clock, and I ask you not to have this discussion now, because I also refer to the Human Rights Convention and about the newest declaration from the WHO who strengthen the human rights. Yeah, but you both are right. When I made with Craig, who is now there, that this book, withdrawn from prescribed psychotropic drugs, we all the time had a discussion with the authors who spoke about shared decision making. We all asked them to use this term, supported decision making, to make clear the last decision makes the patient.
Yeah, Peter, that was my point exactly. That from your explanation, what you were talking about was a paradigm of supported decision making, because last choice was from the person, from the patient. So, and this is a paradigm of human rights, while a shared decision making in the context of power relationship, it can involve coercion, because your psychiatrist can say, no, I'm not agreeing with that. There is a paradigm of consensus that you get, that you need to get with your psychiatrist. And maybe, and he has the power. I mean, he has the power on you in many countries, all the world around. So yeah, what's that point? And I think that you are really talking about support decision making, and but you were using the word shared decision making. But there is some controversy in that. Yeah.
Okay. Well, my point is that I want people to taper safely, and how you call it, it's not so relevant for me in this. So, are there other questions? Nobody?
I would like to know what backlash and pressure not to continue you have had, if any, and Jim as well, and why you attribute, if that has happened, why it's happening from your perspective and experience.
Sorry, what is happening?
If the profession is attempting not to let your research and the practice of prescribing these tapering strips, first is if, I do not know, and second is why you think it's happening. If.
Oh, this is complicated. This is complicated. Well, one thing is, I think it will be happening, even if it's difficult now, because what we are doing, whichever way you look at it, every day we show that it works, and the number of people who are using tapering strips in the Netherlands keep rising, and I can see it from the questions I get, which keep coming in at a daily rate, that people are recognizing these issues and they are using the strips. And since there are, to my knowledge, no comparable alternatives, I think it will be okay, although it is difficult. And why it is difficult, that's a discussion, well, I don't want to have here now. Then we will sit here for another 2 or 3 hours, I think. So I'm confident that it will be okay in the end. But it's difficult, apparently, to get new ideas accepted in this world. And it takes much longer than I expected. That I can tell.
Thank you, Peter.
Paul, I would like to ask you something. Are you okay, Paul? I work together with the German Society for Social Psychiatry, and they made a declaration and sent them to all organizations of doctors, psychiatrists, to prescribe tapering strips about half a year ago. And I would like to know if any orders came for tapering strips from Germany.
I receive prescriptions from patients in Switzerland, Austria, and Germany. Also from Sweden, Denmark, and France. We sent the medication all over the world.
And did you receive more orders in the last
I
6
don't know.
months?
I don't have the figures in my head of how many strips we sent to Germany after you have given the information to the doctors.
Mm.
I don't know, but everything, the tapering strips we sent all over the world are increasing every day. Is that an answer?
Yes, sir.
All right.
Well, this is it.
All right.
No more questions.
No.
Okay. Henrik,
Thank you so much, Peter.
you're
I
welcome.
will say, Alejandra, it's your turn. If you need me to help you with the slides, I will also do it. And honestly, I hope the momentum catches on and we can have what we need, all of us, even if it's like the glasses, exactly your prescription. This is what it works for you. If it's more, it's gonna even make it worse.
Yeah.
As simple as that. Yeah.
Okay.
Yep. If that's the case. Alejandra, do you need me to share the slides?
Oh, yes. A ver si puedo.
Lo hago yo. Alejandra, no te preocupes. A no ser que tú lo hagas ahora mismo.
Rick, si tú puedes, mejor.
Yep, not a problem. I will do it.
Lo pude compartir. Enrique, ¿prefieres que lo comparta? ¿Intente compartirlo ahora desde aquí?
No, dime si se ve bien y ahora ya nos coordinamos.
Vale, perfecto, sí. Ok.
Fantástico.
Hubo como un pequeño cambio, ¿no? En la PowerPoint.
¿Este es el tuyo?
Ok, sí.
Yeah. May it be only because of my computer, Alejandra. So you tell me if this is the one? Yeah, it is because of my computer. It's gonna be like that. Unless you want me to use a PDF, that's the only thing I can do.
Enrique, I prefer share with my
Okay, perfect.
computer. Is
Yeah.
possible?
Let's hope so, yes. Choose to share the entire screen if you have the chance, and that's gonna be it.
Desde aquí, ¿no? Para compartir. No sé si de acá. Creo que, Enrique, vamos a hacerlo con el tuyo igual, porque yo no sé cómo compartirlo por aquí.
Perfecto, lo hago yo con este
Y ya
y
está.
bueno, no pasa nada, es
Ujú.
cuestión de diseño.
Lo voy a leer de aquí ya.
Vale, dime.
So, good afternoon, Rick, and everybody. I would like to begin by thank you for the invitation to participate in this important event from Spain. I am a family doctor in a rural area, and I will share 2 clinical cases of Muslim immigrants from Morocco with diagnosis of paranoid schizophrenia. The Moroccan population residing in Spain today is 900,000 Moroccans. I did my field works working at the mental health of the Moroccan population in a rural area of Spain. I will present 2 clinical cases analyzing the beliefs with the mental health of the Muslim population from the north of Morocco. The next, please. The next. Well, so.
Is it taking a while? I do believe that that's a problem.
I want to, okay, the slide have a move. Case 1, a ver, puedes darle un clic anterior a esa. Esa tiene, Enrique, esa tiene como dos clics para darle para que pueda entrar en la...
Yes, and it's failing. It's not working. Let me see. We're gonna do like.
Okay. Case 1, sleeping child, Moroccan cosmology or paranoid schizophrenia. Moroccan woman who migrated with her husband at the age of 25 to Spain, mother of 3 sons. She went to the health center on multiple occasions with complaint. She denounced her husband for gender-based violence on several occasions. He suffered psychological abuse for several years. During the separation process, she conducted the medical service with the illusion idea of pregnancy that the medical staff ruled out through ultrasound and blood tests. The other, Enrique, please. The woman,
Yeah.
okay, the woman claimed that she took a diagnostic test and she said is pregnant because she had repeated bleeding and her abdomen has begun to grow. After consulting the hospital more than 7 times about her idea of pregnancy, the doctor admitted her to the hospital for the mentally ill. She was diagnosed with paranoid schizophrenia because she thought she was pregnant. At the time of admission, she did not present hallucination. She cooperated with the interview and she had not anxious symptoms. She adapted normally to the functioning of the psychiatric hospital, accepted the rules, had a good relationship with the health staff and another psychiatric patient, and did not alter the sleep-wake pattern. For 20 years, she was prescribed intramuscular treatment of antipsychotic, oral, and anxiolytics, and she took them discontinuously with poor therapeutic adherence, according to the health staff. In general, doctors are aware of the anthropological origin of the psychological distress of Moroccan patients. When interviewing the patient diagnosed with paranoid schizophrenia, psychosmology of the sleeping child in Moroccan patient. The patient had scant bleeding due to a benign tumor in the uterus that subsided after surgery. The patient believed she had a sleeping child who has not woken up for 20 years, and according to her belief, it was because of her husband's fright and arguments. The sleeping child is a social strategy that women sometimes use to explain infertility. The patient has medicated for 20 years with the diagnosis of psychological pregnancy. She took the medication erratically, and when she has hospitalized to remove the benign tumor, her delusions disappeared, and the patient received no further treatment or hospital admission to psychiatric centers. The next, please. Don Galton analyzed the concept of violence in a graphic way to represent the dynamics of the generation of violence in social conflicts. According to Galton, violence is like an iceberg. So visible violence is only a small part of the conflict. At the top of the triangle, as in the visible part of an iceberg, is direct violence. Submerged, not visible, and much more voluminous are structural and cultural violence. Now I classification of the madness from anthropological perspective. In this case, I change this classification with a circle with 3 parts. One part, social madness, another, drug abuse madness, and medical diagnosis madness. Social madness include shame possession, evil eyes, conversion syndrome, psychomotor agitation. The patient family environment bless the shame for the person abnormal comportment. Medical diagnosis madness, in this case, in this circle, all the symptoms are established slowly and progressively. And the other part, drug abuse madness, shame induction of drug use and abuse, low self, lack of migratory project, unfairly to comply with social numbers, unemployed, or social exclusion. The next, please. Okay. According to my perspective, I have modified the triangle into a circle composed of 3 parts, no type of violence system another, but they fit each other, and the origin can be any of them. Being visible of the 3 types of violence, not just the direct one. The 3 types of violence interact and condition each other. So, cultural violence, shame possession, Moroccan social norms, social values, beliefs, and exorcisms. Direct violence include physical abuse, patriarchy, psychological abuse, gender-based violence, self-aggression, and heteroaggressiveness. And the other part of this circle include structural values. In this case, in my opinion, institutional violence is the more important. Psychical contain, drug containment, and incapacitation. The next, please. In this case, I try to explain the beliefs. The moral compassion is in this belief. We need to study the Quran. And in Surah 72, all genes, la Surah 72 of the Quran is called All Shin. This surah focuses on the Shin, spiritual beings created by Allah, and mentions the recognition of the Prophet Muhammad and his message. The surah highlights how some Shin have submitted to Allah and accept the fight, while others continue to go astray. It is a surah that underscores the importance of the acknowledged Allah authority and following divine guides. What's a Shin? Please, the next. The Shin, they are beliefs that they eat, they drink, they are attracted by the blood and repelled by the salt, created by the love from fire. They can be men or women. They cause possession. They can fall in love with their possessed, and they can even have child. They have relation Muslim, Jews, Catholics. They are free will spirit being who cause possession to sleep. The next. What happened to a person possessed by a Shin? The Shin caused the possession of the body of Moroccan people when they suffer strong emotion, frustration, fear, sadness, contact with blood, or are victims of witchcraft if they have internal conflict, forced motherhood, moral submission, religious obedience. The next, please. I saw different things of possession direct, culture, structural violence. The symptoms can range from howling, aggressiveness, attack and scream from the victim, vomiting, abdominal pain in women, insomnia, headache and backaches, poor memory, and seizures. Speak in an incomprehensible language, much less obviously behavior such as anything from poor health to bad relation, including homosexuality. The next. A ver ahí. Below, I will show a short video of an exorcism and the direct structural and cultural violence suffered by my patient who believes they are possessed by spirits. Can put the okay. A ver si puede. Enrique, can put the video, play the video. ¿Mm? Se lo pasé, dice. Pero bueno, no puedo transmitir acá, ¿no? So, what is the different stage of the violence culture and exorcisms? I can so different stage: diagnostic, negotiation with the shame, symbolic violence, expulsion, treatment, and prevention. So what is this? Diagnostic with the shame. I have witnessed exorcism rituals demand start with the question to the shame through the patient to diagnosis, identify the relation of the spirit to choose the type of ritual, as who sent it, whether it is for witchcraft or the shame, can blame the patient for not complying with Islamic rules. The another stage is negotiation with the sheen. In this case, negotiation consists of persuading the possessed body in return that the possessed complies with Islamic moral principle. If the sheen resists, a struggle begins and the holder can be sprayed with hot water, slapped. And the end, when the sheen expulsing of the body and treatment and prevention. In this expulsion stage, the patient may, through object and locomotor agitation, make a cure. In the treatment, the patient agreed to comply this moral recommendation where amulets, where different hijab are not used trap. Another. The next, Enrique, please. And in this case number 2, mystical delusion versus shame possession. A 15 years old patient who migrated with his Moroccan family to a rural area of Spain 20 years ago, the youngest of 7 sisters and separate parents. His mother consulted the doctors because they heard him talking to himself, other time murmuring with God, gesticulation, anguish, and agitation. Psychiatric diagnosis hit him with paranoid schizophrenia and medicate him with oral and injectable antipsychotics. The patient refused to drink and believes he's possessed by the shame and talked to himself. Poor adaptation to the social environment, self-absorbed, muttering with monthly outbreak, lack of medical complaints, and they decide to perform an electroconvulsive therapy. When the doctors prepare in the moment of preparation for ECT treatment in patients diagnosed with schizophrenia and mystical delirium and with pharmacological therapeutic failure, the family, finally, his Moroccan family decided to stop the therapy and make a pilgrimage to a screen in Moroccan and practice exorcisms. The next, please. Currently, the young man is 35 years old. Her mother has died. He lives with one of her sisters. The lack of adherence to treatment persists because the family believes that he is possessed by a jinn. Pilgrimage to Morocco in search of exorcisms continued, and admission to psychiatric hospital with outbreak due to lack of therapy followed by this family and are maintained. The next. The patient said, I was admitted without waiting to. It was more of a operation than a hospital. Everything was locked. Everyone was absent. You can receive visitors, he recalls. The same day I went in, they started injecting me with medication. A nurse putting a finger in my mouth to see if I had swallowed the pill, and they had given me. They hold you among several doctors. They put a strap on my hand and feet. The question is structural violence and pathologization. Why do drugs sometimes not improve the patient's clinical symptoms? Drugs can be useful tools in treatment mental health uses, but they are not the only solution, especially when it comes to Muslim immigrants. The lack of cultural mediators can contribute to misunderstanding and barriers in communication between healthcare professionals and immigrant patients. The next, please. The relationship between mental health and the idea that shame can be influenced mental health is often based on culture and religious interpretation. In some situations, people may attribute hallucination, delusion, aggression, and another experience of mental disorders to the presence of influence of jinn. Moroccan patients travel from Spain to Morocco to perform an exorcism or other rituals to regain their health. Finally, it is essential to analyze the mental health of the Moroccan immigrant population, and in general is a holistic way respecting people, culture, and religious beliefs. Mental health professionals must be sensitive to these beliefs and work collaboratively with communities to ensure a comprehensive and culture competent approach and articulated knowledge. Thank you very much for your attention.
Thank you, Alejandra.
Enrique, no se pudo ver el vídeo. No sé, me gustaría compartirlo si es por aquí, porque es muy representativo del exorcismo que pude presenciar.
¿Dónde lo tenemos?
Te lo puedo enviar si quieres ahora mismo, por correo.
Perfecto, sí.
No sé si lo podrán ver. ¿Ven? No sé, Enrique, creo que va a ser complicado, pero bueno.
Vale. Doy pie a pregunta. quiero decir, doy paso a preguntas y voy buscando si puedo recuperarlo de la presentación en algún lugar.
Vale. Si quieres traducirme las preguntas o si yo las entiendo.
Estaré con el micro abierto.
Vale, vale.
Please, just go ahead and ask Alejandra anything you wish. I will be looking for the video of the exorcism in the meantime.
¿No lo tenemos aquí?
Alejandra,
Sí.
if nobody else wants to ask, when they go to Morocco, does that work for them? Do they come back with the same, or you see an improvement?
Mm-hmm. Yes, I work. A ver que no te veo. Te he perdido.
¿No me ves?
No, no te veo.
Yo te veo a ti.
Tu bebé, vale.
Yeah.
I'll stay with Moroccan people during 7 years. Work in this area in Spain, and I saw a different patient with this problem. Possession seen is very frequently in this area. And the problem is that the doctor don't know the problem, and the medication is only the result. So I want to explain I want to explain that it's very important knew the problem, because in this case the patient is very important articulate the different treatment, not only treatment with pharmacology. It's very important for the patient visit the IMAN and begin the exorcisms.
I have the video now. I'm gonna share it on the PowerPoint online. I can do it.
Yes.
Wait 1 second, and I hope the sound is also gonna be shared.
Yes. Es que lo perdí, Javi, no sé cómo es. Lo tengo, por favor. Es que lo perdí. ¿Mm? Uh-huh. ¿Se le puede dar voz?
That is the only thing I do not know how to do right now.
The violence is the Iman to the person and the Iman to the shin, because is in this case the patient believes in the shin possession. In this moment, the imam intend talk with the shin and negotiation to expel the shin of the body. In this case, the imam showed, and it's when you stay here, it's a difficult moment because the patient was in a state similar of syndrome conversion. At this moment, the Iman put on the abdomen a piece of madera, me parece que es una madera, Enrique, y le hace compression on the abdomen. In this case, we saw 3 types of violence: cultural, structural, and direct violence. If you stop, you can, the video. No tienen el audio.
وعلى آل محمد إن الذين كفروا بآياتنا سوف نصليهم نارا كلما نضجت جلودهم بدلناهم جلودا غيرها يذوقوا العذاب إن الله كان عزيزا حكيما. إن الذين كفروا بآياتنا سوف نصليهم نارا كلما نضجت جلودهم بدلناهم جلودا غيرها يذوقوا العذاب إن الله كان عزيزا حكيما. إن الذين كفروا بآياتنا سوف نصليهم نارا كلما نضجت جلودهم بدلناهم جلودا غيرها يذوقوا العذاب إن الله كان عزيزا حكيما.
That's all, Enrique.
Perfect.
Thank
You were watching the video, right? I shared properly?
Yes. Okay. Thank you very
Thank you.
much.
I'm really looking forward for somebody to ask Beatriz. Go ahead.
Okay. Buenas tardes, Beatriz.
Buenas tardes, Alejandra. Bueno, no sé si hablarte en español es más fácil.
Bueno, si quieres lo hacemos en español y luego podemos traducir nuestra conversación.
I will summarize if you don't mind. Yes, just go ahead and in Spanish, please.
Nada, simplemente decirte que me ha encantado, que me ha parecido muy, bueno, muy interesante y muy potente lo que explicas. Y me preguntaba cómo, desde qué posición habías llegado tú a este trabajo como médica de familia, ¿entendido o no? ¿O habías llegado a entrar en contacto con y a interesarte por lo que estaba pasando ahí, acompañar este tipo de personas, ¿no? Con la situación de migración y con toda esta cosmología.
Sí, bueno, muchas gracias, Beatriz, por la pregunta. Este tema es un tema que lo llevo trabajando desde el año 2014. Soy médica de familia, como te expliqué, y recibo en un día que estaba haciendo guardia, recibo a un paciente joven en estado inconsciente. El paciente, la familia lo trae en estado inconsciente de unos 15 años y ahí comenzamos a tomarle la atención, tomarle el pulso, la glucemia y todo era perfectamente normal. Pero este paciente estaba inconsciente y yo no sabía lo que le ocurría. Lo traslado al hospital en ambulancia y en el traslado el contacto con otra médica y hacemos un traslado entre dos ambulancias y cuando la médica lo ve me dice, es Mohamed, y yo a Mohamed lo conozco porque hace síndromes conversivos de repetición, él y toda su familia. Y bueno, yo a partir de ahí tuve la necesidad de dar explicación a estos síndromes conversivos de la población musulmana en diáspora. Y bueno, y la única herramienta que tenía para entrar e investigar en antropología médica era una llave que la madre dejaba permanentemente en ese joven, una llave, un manojo de llaves en la mano del chico inconsciente. Y de esa manera, a partir de ahí empecé a estudiar y la llave suponía ser, o realmente la utilizaban como elemento para permitir que el yin salga del cuerpo del niño, del adolescente. Entonces, era un síndrome conversivo para los médicos, pero para la población era un estado de posesión por el yin. Estos espíritus creados por Alá, todo musulmán, si cree en Alá, debe creer en estos espíritus, porque están en una sura, en una parte del Corán, en la sura 72. Si tienes un Corán a mano y lo buscas en la sura 72, ahí es donde se habla del yin, y por lo tanto no se puede negar esta cosmología, porque los yines realmente son espíritus que controlan prácticamente toda la vida de la población marroquí, musulmana en este caso. Desde que nacen, durante el embarazo, durante la boda, permanentemente están haciendo rituales para protegerse de estos yines. Bueno, es muy largo, son 7 años de investigación. Si te parece, te puedo compartir mi tesis y bueno, y la leí en el 2021 y la verdad que sigo aprendiendo y agradezco a toda la población que me permitió, porque es en un pueblito de aquí de Ávila donde yo estoy trabajando y entonces con la población marroquí estoy muy agradecida, que me ha permitido conocerlos y conocer toda esta problemática que estoy visibilizando, porque al fin y al cabo, desde la medicina nosotros los médicos decimos que tiene falta de adherencia a los tratamientos, pero es que no escuchamos sus creencias. Entonces, de esta forma creo que a veces no viene la articulación de los saberes. No podemos articular si no podemos escuchar. Y mi pregunta es, ¿se puede articular? Porque en ocasiones, los 2 pacientes que presenté, la mujer que durante 20 años fue tratada con antipsicóticos, ella creía que tenía un niño dormido en su interior. Y el niño dormido es una estrategia social marroquí, musulmana, concretamente del RIF. Y a la mujer se la medicó durante 20 años. Una vez que le quitaron el tumor, dejó de sangrar, el abdomen volvió a su ser y ella ya no pensó más que estaba embarazada de ese niño dormido. Pero fue diagnosticada y psiquiatrizada y patologizada. No sé si respondo a tu pregunta.
Sí, muchísimas gracias. Estaría encantada de recibir tu tesis. Daría para muchísimo. Yo también me tengo que ir ahora, pero me interesaría, si quieres te pongo mi email por aquí.
Sí. Sí, pásamelo y yo con gusto te la compartiré.
Gracias.
Enrique, another.
Yes, I have been sharing the small transcript of what you have been exchanging with Beatriz. Well, everybody can just read it through to believe that this is going to be better. And I have a question, Alejandra. The tumor, during the 20 years, she was bleeding on top of holding the belief in the sleeping child? And there was no medical test whatsoever on the physicality of that.
Mhm.
Wow, that is really telling.
The tumor is benign tumor. So in this case, the doctors no, te lo digo en español, ¿vale? Para reducirlo. Los médicos no consideraron quitar el tumor, porque es un tumor benigno, es un mioma. Los miomas en general no se operan, no se intervienen, sino dan amplia patología. Es un tumor benigno bastante frecuente en las mujeres. Pero en este caso se lo dejaron 20 años y la mujer fue patologizada durante 20 años. No sé si lo querés traducir para los compañeros.
Yeah, it was benign, they knew, and they preferred not to take it because it was just too common and not a problem. Ellos sabían que había el tumor, que el sangrado existía debido a eso, and that eso fue lo que ocurrió. Okay. And at the end, how that got solved? The belief, the medication, the drugging. At some point, it stopped. What happened? How that came to be, etc. That is like the resolution.
Yes. Cuando la mujer fue operada, finalmente se dieron cuenta que no tenía esquizofrenia paranoide, que durante 20 años la fueron tratando con antipsicóticos orales de primera y de segunda generación, atípicos y atípicos, y finalmente cuando le quitaban el tumor, la mujer ya dejó de pensar en el niño dormido. Y ya está. Pero la mujer sabiamente no se tomaba la medicación, Enrique, se la tomaba cuando le venía bien.
¿Y se la sigue tomando, sabes?
No,
No,
ya no
jamás.
se la sigue
Ya
tomando.
nunca.
La mujer no sufre de esquizofrenia paranoide.
¿Significa eso que se la tomaba, le venía bien porque los test de sangre o algo así, quizá?
Sí, porque ella se ponía muy nerviosa cuando tenía el sangrado, entonces regresaba al hospital, al centro de salud diciendo yo estoy embarazada, quítenme este niño, el niño está dormido, y entonces le volvían a hacer otra vez el test, le volvían a hacer la ecografía y volvían a ver que el niño no estaba dormido. O sea, volvían a ver que no estaba embarazada, entonces pensaban, esta mujer tiene un embarazo psicológico. Y se quedaron en el embarazo psicológico. La mujer nunca tuvo un embarazo psicológico. La mujer, una vez que la operaron, dejó de pensar en ese niño, pero lo que quiero resaltar es que durante 20 años fue patologizada y sobrediagnosticada. Y no se tuvo en cuenta porque no tenemos médicos que hagan etnopsiquiatría, no tenemos tampoco esta figura que me gusta tanto a mí, que son los mediadores interculturales, no los tenemos. Y entonces, al fin y al cabo, las creencias quedan dejadas de lado.
Yeah, lo voy a traducir. Alejandra is asking, is saying that cultural mediators are very important. We should have them. That this patient for 20 years kept on believing what it was assumed was the reasoning, our kind of medical doctors, use as she is believing that she is paranoid and schizophrenic. She took the medication, she kept on believing up to the point that she got the intervention for the tumor, out the bleeding, and also there is no issue, no problem. She didn't, on her own volition, take medication anymore when nobody was forcing her. And this is, in this case. Do you want to introduce the other one or go ahead with the possessions? Anything else? No? Okay, it's fantastic. Alejandra, thank you so much.
Thank you so much for you, y discúlpame por mi inglés tan precario, pero bueno, quería presentarlo para que ellos me pudieran comprender, porque en realidad esta población musulmana no está solamente aquí en Marruecos. Fíjate el Islam cómo se ha expandido y cuánto tenemos que aprender todavía de la población musulmana.
It is something that we just simply don't know. Even anthropologists, we do not know how this works, and it's shameful. The genes, the different cosmologies, and asking which religion you are from, and in a previous life, what is this exactly? It's amazing that we do not dare to delve deep in and take it seriously as it is. Yeah, thank you so much, Alejandra.
Thank you for you.
Thank you. Peter, Craig, do you want to just jump in? If not, Alejandra, I assume that it was previous life, but it's a different kind of being. ¿Nos puedes explicar exactamente qué es un jinn?
Te lo explico a ver. Te lo explico, te lo resumo a ti para que tú se los expliques. Un jinn es un espíritu creado por Alá. Está en el Corán, por lo tanto, los musulmanes, si creen en Alá, tienen que creer en el jinn. El jinn puede entrar en el cuerpo. Si quieres ir traduciéndolo.
Jinn is a being created by Allah. It can go inside the body of a human being. It's a spirit.
The spirit, bueno, tiene gustos. Les gusta mucho los dulces. Comer dulces. Pero odia la sal. La sal, por eso, se utiliza en algunos rincones de la casa para ahuyentar al jinn.
They have preference for sweets, but they do not like salt. So salt is used to scare them away. They, as people that holds this belief and want to scare them away, positions the salt in a place in the house, to a corner.
El jinn también se ve asustado o no le gusta el metal.
Metal is something they don't like either.
Por eso la madre de este chico de 15 años ponía en la mano un manojo de llaves de metal para poder darle la oportunidad que el jinn salga del cuerpo de su hijo.
That's why the mother of the boy in the second example placed keys in the hands of her son, my apologies, to let the jinn know that she's offering a way out.
Toda la familia de ese chico de 15 años hacía síndromes conversivos semanalmente.
All family was showing conversion syndromes every week.
Y por supuesto que los psiquiatras en el hospital no comprendían este fenómeno, ni tampoco sabían qué ponerle de tratamiento, porque no le puedes poner ansiolíticos y gracias a Dios no se le pusieron antipsicóticos, porque es que toda la familia hacía síndromes conversivos. Eran 8 personas con síndromes conversivos semanalmente.
Okay, it was every week 8 persons in that family showing conversion symptoms, which Alejandra, ¿qué es exactamente lo que les ocurría? In any case, the team, the psychiatrist that was treating them, they didn't know what to do with the boy or anybody. ¿Qué es lo que ocurría exactamente?
Un síndrome conversivo es, en realidad, cuando el paciente no se encuentra bien con el medio que lo rodea, una falta de adaptación social, pero no es una enfermedad que necesite medicamentos. Convierten sus angustias en pérdida de conocimiento, mutismo, ansiedad, parálisis facial periférica, con sintomatología que dura escasos minutos o días y sin tratamiento se resuelve. Pero es una manera de manifestar la no adaptación al medio que lo rodea. Eso es un síndrome conversivo. Lo que ocurre es que aquí en España se intenta medicalizar el síndrome conversivo.
Well, it was simply malalignment with the context that they were living, manifested by paralysis in the face, anxiety, other stuff that the medical doctors did attempt to treat with drugs or whichever the mechanism that we are used to, yet they didn't find how to. And what was the resolution in this one? If the family...
Finalmente, la familia peregrina a Marruecos para realizar exorcismos. Y una vez que el jinn no está en el cuerpo, la salud mental viene a la familia y viene a la persona. Entonces, los exorcismos y acudir a un imán, realizar visitas a los santuarios, acercarse a la mezquita y comenzar a rezar, son todas, al fin y al cabo, terapias no farmacológicas que resuelven estos conflictos.
They went back to Morocco, they did a journey, a peregrinación, visited temples, prayed, and that helped them to get over the problems they had. If it was exorcism, they had also that kind of things. We don't know. I picture it's a really fascinating case, if you want to treat it like that they did manage, right? Anyhow, Alejandra, it is a wonderful line of work, and hopefully we're going to learn all together way more. Share with me anything you want, and I will post it once the recording's on. Yeah?
Okay. I'll give you my thesis complete.
Fantastic. And on my end, I don't have any other question. I will just let Peter and Craig go ahead. Thank you so much, Alejandra.
Bye.
Thank you.
Thank you for you.
Peter, do you need me for the slides or something?
No,
No?
Should I start? Should I
Thank
start?
you so much. Yes, go ahead, please. Sorry for the little bit of delay. It's because, yeah, my bad. Yeah.
Okay. Will you announce our topic?
Yes.
Please.
You are going to talk about the lower level violences, which is not, it is depending of your point of view, that you do not have alternatives. The patients, we do not have the alternatives to just go for the psychological treatments or anything else. This kind of we are not talking about big human rights violations, but this is something ongoing and it happens to everybody. It's mass scale. This is the topic that you're gonna cover, if not mistaken.
Okay. Greg and I, we will speak about human rights violations via misinformation about the risk of dependence of psychotropic drugs and the denial of support and withdrawal. Myself, I'm a certified pedagogue, a social scientist, and an independent publisher in Berlin, Germany. Until 2010, I was a long-standing board member of the European Network of Ex-Users and Survivors of Psychiatry. This means I belong to the group of people with lived experience. I deal with the topic of withdrawal from psychedelic drugs since more than 50 years. Give lectures and training also for psychiatrists in clinics. And I published books about this topic, for example, Coming Off, Psychedelic Drugs, also in German, French, Greek, and Spanish. It was the first book in the world about successful withdrawal from neuroleptics, antidepressants, and other drugs. And together with my friend Craig, you see him, recently I edited the book, Withdrawal from Prescribed Psychotropic Drugs. Hopefully, Enric can enable translations into French and Spanish. Last Friday, in Enric's lecture series, Political Abuse of Psychiatry, the former Human Rights Council Special Rapporteur Daniel Duras spoke in his impressive presentation about political abuse of psychiatry, amongst other places in the former Soviet Union. After his lecture, I have asked him whether he could see the border between the misuse of psychiatry and its correct therapeutic use. Admittedly, a difficult question that probably cannot be answered straight away. Afterwards, I set about asking the same question myself. On Wikipedia, I found a page, Political Abuse of Psychiatry, and there the definition of Robert van Boren. Robert is the chief executive of the Human Rights and Mental Health Federation Global Initiative on Psychiatry. I cite him. Political abuse of psychiatry, also commonly referred as a punitive psychiatry, is the misuse of psychiatry, including diagnosis, detention, and treatment for purposes of obstructing the human rights of individuals and or groups in a society. End of citation. Craig and I are talking today about informal psychiatric human rights violations. For this reason, I would like to broaden differentiate the understanding of political abuse of psychiatry in this form. Macro and micro political abuse of psychiatry is the use of psychiatric diagnosis, of detention, of coercion, of administration of psychotropic drugs and electroshocks without informed consent, or with misinformation about treatment risks, inclusively risks of dependence on psychotropic drugs, and withholding of support in their withdrawal for the purposes of obstructing the fundamental human and civil rights of certain groups and individuals in the society. This would be my definition. I don't want to talk about macro political abuse. Others have already talked a lot about it. Formal coercion is well known. Informal coercion is less visible, has so far been little addressed, is no less profound in its effects, and is a pervasive psychiatric practice worldwide. Informal coercion is characterized, between others, I repeat, by withholding information about the risks of prescribed psychotropic drugs, by concealing the risk, particularly on antidepressants and neuroleptics, and by withholding of support in their withdrawal. These substances have a number of toxic occasional, life-threatening, or even fatal adverse effects, whether they are administered compulsorily or with the approval of the affected person. People with serious psychiatric diagnosis and appropriate treatment, that is, administration of neuroleptics and antidepressants, have a reduced life expectancy of 20 to 25 years on average. And these substances cause physical dependency. Now I have to mention some psychiatrists. Rudolf Deckwitz is a former director of 2 psychiatric university hospitals in Germany and also a former president of the German Society for Psychiatry and Neurology. He was the first psychiatrist in Germany to provide specific information about the risk of drug dependence on neuroleptics and antidepressants. In 1967, he wrote about psycholeptics, which include antidepressants and neuroleptics. I cite, "The reduction or discontinuation of psycholeptics lead to considerable withdrawal symptoms, which are in no way different from the withdrawal symptoms following the discontinuation of alkaloids and sleeping pills." End of citation. The chemical group of alkaloids includes, for example, morphine, well known for its potential to build dependency. Its withdrawal can also bring major problems, including life-threatening circulatory disorders with shock states. And already in 1965, Deckwitz had written about neuroleptics. I cite, "We know now that it is extremely difficult, if not impossible, for many of the chronic patients to stop neuroleptics because of the unbearable withdrawal symptoms." End of citation. Gerhard Gründer is another German psychiatrist. He's a former chairman of the Task Force Psychopharmacology of the German Society for Psychiatry and Neurology. He warned of a vicious circle that can arise from continued neuroleptic drug use. Not publicly, but in his technical book addressed to his colleagues, he wrote in 2022, I cite, "The development of supersensitive dopaminergic systems illustrates the dilemma of antipsychotic pharmacotherapy. Every treatment with dopamine 2 receptor antagonists, these are substances directly against the action of dopamine 2, potentially carries the risk that supersensitivity of the target receptors will develop. However, once this has occurred, a vicious circle of tolerance development, dose increase, and further progression of the pathophysiological process often follows." End of citation. Similarly, in the same year, the Italian psychiatrist Giovanni Fava warned in his book, Discontinuing Antidepressant Medications, of the consequences of adaptive responses of continued administration of antidepressants, which involve changes of special subtypes of serotonin receptors. I cite, "The clinical events that may follow tapering and or discontinuation of antidepressant medication are very variable. They may range from no or limited withdrawal symptoms to severe withdrawal syndromes. They may occur within days, if not hours, or have a delayed onset. They may fade away or persist for months or years, accompanied by new disorders and or greater intensity of the original disturbance. Further, withdrawal and persistent post-withdrawal disorders may be associated with other manifestations of behavioral toxicity, such as a loss of clinical efficacy, paradoxical effects, switching to bipolar cause, resistance, and refractoriness. Drug firms and doctors withheld a warning of those affected and their relatives from tolerance formation of psychiatric drugs especially of antidepressants and neuroleptics. Most of the psychiatrists deny the risk of drug dependence on antidepressants and neuroleptics with these arguments. Withdrawal, or how they call them discontinuation symptoms, are only a symptom change of the diagnosed disorder, are greatly overstated and solely signs of medical mismanagement and due to too rapid discontinuation, are usually mild, self-limiting, and only in extremely rare cases classified as more severe, are merely reported among the layperson withdrawal community, and the resulting publications are filled with anecdotal reports of bad outcomes. Are neuroadaptive processes, as they also occur when discontinuing drugs prescribed in physical medicine. And persistent withdrawal problems are only incidental ones. If an antidepressant discontinuation syndrome occurs, for example, the DSM-5 guidebook names one easy possibility of solving the problem: taking antidepressants again. This way of dealing with withdrawal symptoms is not new. People dependent on alcohol also alleviate withdrawal symptoms by continuing to reach for the bottle. Finally, and this is the killing argument, there is no craving for antidepressants or neuroleptics, but craving for a substance would be indispensable condition for the existence of drug dependency. Okay, so far the community of psychiatrists who deny the existence of drug dependence on neuroleptics and antidepressants. Craving as a crucial characteristic of dependence was incorporated into the definition of drug dependence in the psychiatric classification systems in the interests of the pharmaceutical industry. Court judgments in the 1980s had led to convictions of psychiatrists who had not warned of the risk of benzodiazepine dependence. The judicially enforced information about the risk of such a drug dependence had led to a significant decline in the sales figures for these substances. To think that people feel a craving for neuroleptics, that means for substances that are administered in totalitarian states to punish and torture dissidents, requires a dark imagination. And it's so absurd. Nobody has ever claimed that there's a craving for neuroleptics and antidepressants. You could just as easily claim that a drug dependence only exists if the person concerned over time grows an elephant's trunk out of their face. And perhaps many would also fall for such a definition if it were only spread by people in white coats or with medical doctor titles. There are groups in Germany and outside, for example, the International Institute for Withdrawal of Psychiatric Drugs, who publicly criticize these primitive tactics. We are not alone. In its report to the General Assembly of the United Nations in 2015, the Human Rights Council Working Group on Arbitrary Detention demanded not only the immediate cessation of any forced treatment, but also non-psychopharmacological assistance. And in its guideline number 20E, the final demand was, I cite, assistance in withdrawing from medications should be made available for those who so decide. End of citation. In the same year, this demand was included in the same wording in Guideline 14, the right to liberty and security of persons with disabilities of the UN Convention on the Rights of Persons with Disabilities. And in October 23, last month, 2023, the World Health Organization and the United Nations High Commissioner for Human Rights demanded in the protocol Mental Health, Human Rights and Legislation not only a higher standard for free and informed consent, but also a governmental initiative to guarantee by law support in withdrawal. I cite, legislation can require medical staff to inform service users about the right to discontinue treatment and to receive support in this. Support should be provided to help people safely withdraw from treatment with drugs. End of citation. We should be aware of these important statements and call on governments and administrations and organizations in the psychosocial field at all levels to implement these all too justified and overdue demands without delay. Experience has shown that the lobbyists of the pharmaceutical companies and the organizations of mainstream psychiatrists will do everything in their power to undermine effective measures against the micropolitical abuse of psychiatry. Until this happens, the programs of support and withdrawal, it's our task to do everything in our power to publicize the risks and harms of prescribed psychotropic drugs and to develop a system of competent support for the self-determined withdrawal, with further training, with publications, digital as well as analog, by participating in self-advocacy organizations and organizations of humanistic psychiatry, or in organizations that seriously want to reform psychiatry in the direction of human rights-based assistance. Of course, it would be even better to develop a system of psychosocial support in which psychotropic drugs only play a subordinate role. I mentioned some statements. You can find some of them and their sources on the internet. The address is peter-lehmann, LEHMANN.de, D like Denmark, E like England, /ABC. And you can find all of them in my chapter for and against dependence on antidepressants and neuroleptics who benefits in the book Withdraw from Prescribed Psychotropic Drugs. This book, which I mentioned already, is about practical withdrawal concepts for professionals, patients, and relatives. Craig Nunes will now continue together with him. I've published the mentioned book. Thank you very much for attention. Craig, now it's your turn.
Can you hear me now?
Yes.
Okay. Well, thank you, Peter. Wonderful as ever. I shall say a very small, a little bit about me, not very much. The first thing to say is you can find, if you just Google my name, Craig Nunes, you will discover all the books I've published, all the activities I've done, etc., etc. I don't just publish psychology and critical psychology books. I've written novels, I've written children's books, and all of those are on, you'll find them on Google. I've been editor of this, the Journal of Critical Psychology, Counseling and Psychotherapy, for 35 years. So I'm getting quite old and tired. And I guess the main kind of brief of the journal is to critique all the claims that psychotherapy, psychology, and psychiatry make. And that's very easy to do because so many of the claims are simply claims. They're not based on real entities. So, for example, the id, the ego, and the superego, they don't exist. They're just names. Schizophrenia doesn't exist. Behavior exists, conduct exists, but schizophrenia there is absolutely no construct validity or reliability for that particular construct. It's just a word. And JCPCP says that kind of thing a lot. I'm going to critique a little bit our own book, because I spend my life critiquing things. So this is the book that Peter mentioned, Withdrawal from Prescribed Psychotropic Drugs. I would recommend it. It means that I can eat dinner because I shall make a great deal of money. I don't think I will. However, what I'm going to talk about are there are many, many suggestions in this book for how to safely withdraw from psychotropic drugs. I'm going to talk about several things that make that very difficult. So, for example, the networks that this book suggests, networks that include compassionate psychiatrists, good general practitioners, kind relatives, friends, many of these networks simply don't exist. If they existed, people wouldn't get into trouble in the first place. So that's one problem. A lot of networks aren't available. Another problem is that deprescribers, people who systematically reduce the dose of the drug, they're also very unusual. What tends to happen, as Peter mentioned, is that if someone is experiencing withdrawal effects, what will happen is they will increase the dose, not decrease the dose. There's also a simple problem of the sheer volume of work for the staff involved. So junior doctors, care staff, they have an enormous amount to do and not very much time to do it. Because of that, it becomes much easier to simply give somebody a tranquilizing drug. And although we call them antipsychotics, they're not antipsychotics, they're just tranquilizers. It is just easier to give someone a tranquilizing drug, because if that person is doing something very difficult in a care home, then, and there aren't many staff, then for the staff, it is easier to give the drug. If it is a junior doctor who goes out into the middle of nowhere, goes out into the, I live in a very countryside, a rural place. And if there were a junior doctor